So in my presentation, I will be discussing the epidemiology of hepatitis B in children, prevention of mother-to-child transmission of hepatitis B, some research gaps in hepatitis B and pregnancy, particularly in Africa, diagnostic challenges, and the way forwards. So if we look at viral hepatitis in Africa, around 5 to 8% of the population, mainly in West and Central Africa, are infected with hepatitis B, and around 2 million are co-infected with HIV as well. However, the situation of hepatitis Delta is poorly understood. Hepatitis B in children is really important from a clinical perspective and a public health perspective. Clinically, infants are mostly asymptomatic. They will have normal ALTs. We do not usually screen pregnant women, and we need to diagnose them in the setting of pregnant women screening. The birth dose vaccination coverage globally is fairly poor, and progression of liver disease in the high risk and immune compromised populations of children are high. And there is also a risk of hepatocellular carcinoma, particularly in adolescents. From the public health point of view, children can transmit infections, particularly those with high viral loads and immune tolerance. Virus suppression as prevention is very important during the adolescent phase where there is high risk behavior, and globalization, immigration allowed a lot of infected children to infect populations who were having a lower prevalence of hepatitis B. And there is also lack of screening policies for both children and women in childbearing age. And indeed, global elimination of hepatitis B is not possible if we do not include children and women in childbearing age. 1.2 million adolescents aged 10 to 19 live among us globally, making up around 16% of the world's population. And if we look at the African population, 40% to 50% are below the age of 25 years. There is also something critical about infection in children, the fact that chronic infection is much higher the younger the ages. So those who are infected from their mothers have a risk of almost 90% of being infected with having chronic infection with hepatitis B, particularly those born to E antigen positive mother, and the risk is lower as the children grow older. If we look at the global burden of hepatitis B in children and adolescents below the age of 18, it's estimated to be around 50 million infected below the age of 18 years. Those are not captured, are not known, and they are transmitters of disease. Only 84% of countries vaccinate the 3 doses of hepatitis B, and 39% only vaccinate also the birth dose. The S antigen, though, because of the vaccination, dropped from 4.5% to 1.3% in the vaccination era from 2000 through 2015. This is the S antigen prevalence coming from all countries with data modeling or extrapolations from those 5 years old. And as we can see, the Western and Central Africa have the highest prevalence rates, above 2% in children below the age of 5, with a little bit of a lower prevalence up to 2% in the southern part of Africa, and it's less than 1% in North Africa. As we can see that the coverage of the 3 doses is up to 80% in Africa of the hepatitis B. For the birth dose, the coverage is no more than 10%, and there is no coverage for the hepatitis B immunoglobulin or the prenatal, prophylaxis for pregnant women. The situation of Delta also in children is completely unknown, except very few case reports with either super or co-infections. So according to the WHO Afro region, only 15% of the countries are leading prevention efforts and are vaccinating, giving the birth dose with the pentavalent vaccination of more than 90% coverage. Less than 8 countries provide the subsidized testing and treatment, and the birth dose in early infancy, as we know, is the most effective way to prevent transmission. It has a very low cost to prevent mother-to-child transmission. It's less than 20 cents per child. Only 11 countries in the region are following this protocol, including Cabo Verde, has almost achieved more than 99% vaccination birth dose coverage. If we look at the mother-to-child transmission, those mothers who are e-antigen, S-antigen positive have a possibility of 90% transmitting the infection to their infants, while those who are e-antigen negative have 5 to 20% possibility of transmitting the infection. But most of the mothers who have prophylaxis failures, these occur at thresholds of maternal DNA levels of 10 to the 6 to 10 to the 8 copies per mil. But those are some of the pooled studies for e-antigen positive and negative women from 11 African countries, looking at the pooled risk of a little bit of a lower risk without prophylaxis of 38% for the e-antigen positive mothers and 4.8% pooled risk for the e-antigen negative mothers, with around 360,000 HBV infected infants perinatally in sub-Saharan Africa. How about intrauterine transmission? It has been proven, particularly in mothers who are e-antigen positive with only the structural HBV protein that can pass through the placenta is the e-antigen. Sometimes with amniocentesis, transmission can happen. But the majority of transmissions happen intrapartum, where the mother-to-child transmissions, there's some mucosal breaks, microtransfusions, hematologic leaks during delivery or interventional delivery, and sometimes with the electrodes in infants that the transmission can happen, but there is no difference between vaginal and C-section, so we should not expose mothers to a higher risk of cesarean section to prevent hepatitis B, because it has no role in reducing the risk of mother-to-child transmission. Breastfeeding has no role or minimal role, particularly only in mothers who have cracked nipples. However, with proper prophylaxis, breast milk should not transmit hepatitis B. So if the mothers are given treatment, we give HBIG or without even, and give the timely birth dose, it should not, this should prevent the mother-to-child transmission, and we should not prevent breastfeeding, which is really important, particularly in low and low middle income countries. The natural history of hepatitis B in children is very unique. Neonates are mostly asymptomatic, but some of them might present with fulminant hepatitis. However, a very unique condition of the skin called Gianotti-Crosty syndrome, a papillary acrodermatitis, might present in some of the infants above the age of 6 months, in addition to young children. And they usually have mild fever, lymphadenopathy. They usually don't have jaundice. And in children and adolescents, however, there might be mild constitutional symptoms and occasionally, and very rarely actually, fulminant hepatitis. But we might encounter extrahepatic manifestations like membranous glomerulonephritis and sometimes rapid progression of liver disease in children, particularly those who are immune compromised, or those with cancer, thalassemias, blood diseases, etc. Cirrhosis and hepatocellular carcinoma happen in around 1 to 3%, and hepatocellular carcinoma risk is 1 over 1,000 per year. We've seen adolescents with hepatocellular carcinoma. Spontaneous clearance of e-antigen can happen more in Western children, lower in the Asian population, and there is a difference in the background of immune response. The e-antigen seroconversion rate is around 4 to 10% annual rate, up to 70% by the end of adolescence, and we have a minimal 0 to 1% annual rate of S-antigen loss, e-antigen positivity. The Asian population, particularly those perinatally infected, are less likely to clear the hepatitis B, and there is more active disease beyond adolescence and more favorable evolution, particularly in females of genotype B. This is a natural history study of a 25 years experience of 252 e-antigen positive cases, almost 60% had infected mothers, 77% were Asians, 33 received interferon. E-seroconversion rate was 41.7% over almost a 19 years period of follow-up. But there are many changing concepts of immune tolerance and chronic hepatitis. First, we have the EASA classification, the new classification for E antigen positive chronic infection, then chronic hepatitis, E antigen negative chronic infection, then chronic hepatitis, and the S antigen negative. The majority of children have high viral loads, but they have normal transaminases, the so-called immune tolerant chronic hepatitis B. It's not always innocent. Some of them, it has been recently known that some of those immune tolerant cases might have high replicative low inflammatory disease with substantial histological lesions. So, and DNA integration. So liver biopsy in some cases might be still indicated, particularly in the so-called immune tolerant population. And the majority of those are the childhood and adolescent population. This is an example of a 5-year-old child with chronic hepatitis B, elevated transaminases for more than 6 months, E antigen positive, S antigen positive, DNA more than 3.7 times 10 to the 8 international units per mil, previous infection with hepatitis A, ultrasound showing bright liver. Liver biopsy showed minimal inflammation, mild portal fibrosis, but also 5% only as antigen positivity and less than 1% core antigen positivity as a nuclear reaction. And in fact, the brilliant pathologist told me, wait, is going to clear the virus. And within less than 1 year, this child completely cleared the virus and was S antigen negative and antibody positive, anti-S positive. And that was really very rewarding. And the liver biopsy here was really rewarding because this child did not receive treatment and spontaneously cleared the virus. So those are the treatment recommendations in children for those who are E antigen positive, aged between 2 and 18, with both elevated ALT, measurable HBV DNA, with the goal of achieving E antigen seroconversion. ALT elevations more than 1.3 times upper normal limit, at least 6 months with HBV DNA elevation. However, we usually wait longer, especially if you have the expertise. You know sometimes that those children might clear the virus and you can wait a little bit longer, particularly if they have normal fibroscans or normal liver biopsies. DNA levels are very high, more than 10 to the 6 international units per mil. If they're a little bit lower, we can even wait longer. Interferon alpha-2b is approved for children 1 year old and above. Lamivudine and entecavir approved for children 2 years and above, and tenofovir approved for children 12 years and above. Duration of interferon is usually 24 weeks, but oral antivirals, they've been followed up after 4 years and even 6 years. I have children and adolescents, and they became adults now, who have been on treatment for 15 to 20 years. E antigen seroconversion once happens, we wait 12 months for consolidation and then we stop treatment. However, we continue following up for every 3 months for ALT flares or for reactivation of the virus. So to control hepatitis B in children, we need surveillance, proper infection control practices that has been recently strengthened by the COVID-19 crisis, improving blood safety, timely birth dose, hepatitis B birth dose to prevent mother-to-child transmission. Education and awareness are key, particularly among pregnant women, among pediatricians, among healthcare providers, obstetricians and gynecologists. Research is gender for the gaps, very important. And we use treatment as prevention sometimes to suppress the virus in those who are eligible for treatment, to prevent progression of liver disease and remove the stigma and discrimination among children, particularly in schools and when they play sports. Also prevent reactivation of the S antigen in the immune suppressed and compromised population, and prevent transmission of the virus in the high-risk population, and indeed prevent mother-to-child transmission. So the dilemma is that the only approved drugs and antivirals are entecavir for children above 2 and tenofovir above 12. However, these are not accessible in most of the countries because the syrup for entecavir is not available. And if we have a smaller child who needs treatment, probably the treatment will not be available except in a tablet form. For research, there are many trials now for also the TAF, the tenofovir alafenamide. And the TAF has been used in HIV in adolescents and children, and it's being tried now in adolescents with chronic hepatitis B. And there are studies also for entecavir and pegylated interferon for the immune tolerant population, but the results are not very rewarding. So what are the strategies for prevention? Maternal screening, of course, timely birth dose within the first 24 hours, and hepatitis B immunoglobulin, if available, with completion of the hepatitis B vaccination courses, and of course, using the antivirals for women who are at a higher risk with high viral loads. But when we look closely at prevention of mother-to-child transmission, we will find that this is really important, that we start treatment of mothers a little bit earlier or in the last trimester of pregnancy. Because as you see from the right side, that transmission can happen in utero. And also because of the fact that it can cause preterm birth, low birth weight, premature rupture of membranes, gestational diabetes, possible small increase in congenital anomalies. And those are some of the pregnancy outcomes that have been reported. And there are many studies looking at the effect of drugs during an antiviral therapy during pregnancy, and tenofovir has been the winner for use in mothers in the last trimester of pregnancy. So those are the Advisory Committee for Immunization Practices, maternal screening recommendations. Mothers should be tested for S antigen at the first antenatal visit, and should be tested again for S antigen, even if negative earlier, if she had more than one sex partner in the previous 6 months, had an evaluation or treatment for sexually transmitted disease, was an injecting drug user, has an S antigen positive sex partner, or was diagnosed with clinical hepatitis since the last visits. And WHO highlighted very clearly that despite some interventions like vaccinations, and among all reasons for vertical transmission, high maternal viral load was the key cause for maternal transmission despite interventions. This led to the recommendations or the new guidelines of the WHO published during the World Hepatitis Day in 2020, looking at triple elimination of both hepatitis B, HIV, and syphilis, and also looking at treatment of mothers, recommending treatment of mothers with tenofovir prophylaxis at the 28th week of pregnancy if the HBV DNA is more than 200,000 international units per mil, and using the hepatitis B timely birth dose vaccination within the 24 hours as a key performance indicator, and of course giving the hepatitis B immunoglobulin in addition if available in some countries. So the conclusions for treatment: vaccination for prevention is the most effective way to control infection. Majority of children with chronic infection have high viral loads and normal ALTs and not responsive to current therapy. Viral therapy should be considered for therapy. We should always remember that we need to test women in the childbearing age and screen women in the childbearing age even before they get married or get pregnant. Screening is a key to elimination of hepatitis B and maternal antiviral treatment and infant post-exposure prophylaxis. The full beneficial effects, though, of universal and birth dose vaccination will not be seen in Africa before 2 to 3 decades. Now we have almost 70 million infected, 1.4 million diagnosed, 20 million eligible for treatment, but only 33,700,000 treated, less than 1% access therapy, less than 1% of pregnant women treated, and around 3.4% prevalence in children 5 years old. 19% only received the birth dose and 10% the timely vaccination. So we need to push very hard. I would like to hopefully incentivize and push all of you to push your governments to start the birth dose and start the universal screening for pregnant women for S antigen or for S antigen HIV and syphilis, and also to integrate within the universal health coverage, including awareness and education, and improving the state of lower tier healthcare facilities serving rural areas and investing in the health of African mothers. Community and civil society engagement, and this year it was all about the World Hepatitis Alliance, FIND Diagnostics, WHO. It was all about mothers, women's health, and prevention of mother-to-child transmission, and we need to simplify the diagnostic algorithm and address our research gap, particularly in Africa. So as mentioned earlier, engagement of key stakeholders and prioritization of pregnant women in the cascade of viral hepatitis is key to elimination. And to conclude, we need to tailor the prevention of mother-to-child transmission according to our setting, with optimal implementation of birth dose, timely implementation, vaccination, also treating women with high viral loads, prevention of infections in girls and women living with HIV, and we can integrate into the HIV programs and in the harm reduction programs for the persons who are injecting drugs, and then simplify the diagnostics and improve access to affordable treatment. Thank you very much. Merci beaucoup.